Okay. Good morning. My name's Gillian Dacey, and I work with Public Health England. And say thank you to Stefan for inviting me here to speak to you about an exercise that we conducted in 2010, 2 years before the Olympic and Paralympic Games in London. And this was part of the preparation for the Olympics, for the health services in particular. It was not part of the official Olympic preparation program, but one that we felt was important to do. And it focuses on the needs and requirements of people with disabilities. Because of the Paralympic Games, we felt that perhaps the health services were less prepared than they should be to deal with large numbers of people with various and variety of disabilities. So that's why we conducted the exercise, and my role was to lead the team and to develop the exercise and deliver it on the day. It was a large field simulation exercise involving a significant number of volunteer casualties and staff from across emergency services and a hospital in East London where the games were taking place. So what was it all about? Well, the aim of the exercise, as stated here, was to look at the preparedness of health services in London and to see if they could cope with a large casualty event involving a significant number of disabled people with a variety of disabilities. These were some of the objectives. There were a significant number of objectives for the exercise, but these ones here I think are most important and relevant to us at this event. And it really focuses on how the NHS and the resources, and do they have the capacity to deal with people involving at a chemical incident and involving potential decontamination and the clinical treatment of those patients. And the last one there, I see the communications as being a recurring theme for today already, and that was a significant issue for us in the exercise. For those of you that are familiar with London, this is a part of the map of East London, which just goes to show the variety of where the exercise was spread out. The Olympic Stadium was just through in here, was just in this area in here. So we decided that we'd have the exercise take place close to the Olympic sites and replicate as much as possible the events of the day. The scenario that we used was an accidental chemical release of a chemical that would have required decontamination of people should they have been in contact with the chemical. And we had a number of able-bodied and disabled athletes and spectators involved in this fictitious event. And we were looking at approximately 100 casualties, of which the breakdown I'll show you shortly in terms of the numbers of casualties. The incident site that we set up for the event, it's a bit hard to show here, but the actual incident took place and the chemical was released at this end up here. And then the idea is that the emergency services will then rescue the patients and move them through a process of decontamination until they come out this end when they're all washed and cleaned and dried. So it was a significant setup there, of which we pre-scripted a certain amount at the beginning of the exercise so we could focus on the main outputs, which was looking at how the clinical treatment and transport of disabled people through London. We had 96 volunteer casualties in total, though we had planned for 113, but we had some no-shows during the day. There were 188 participants, i.e. members of the emergency services and hospital staff participating. And we had 212 staff from across 19 organisations just simply preparing for the event. So this is a big-scale event for us to put together. And to make it even more challenging, we had members of the broadcast media present. So the BBC and the Press Association were present as well to film it and to add a bit of pressure in terms of communication with the public. Because of the size of the event, we had a 5 o'clock start in the morning, and we had access to the Homerton Hospital in a live capacity. So we were sending simulated patients into the emergency department, and the hospital gave us access to the emergency department alongside members of the public turning up for treatment during the day. So it was a real privilege to be able to have access to a hospital for an exercise such as this. This is just a bit of a summary here. I think I've covered most of that. And this is the bit where I want to start focusing on the volunteers and the breakdown of the casualty population that we used for the day. They were volunteers and they didn't receive any payment for the exercise, but they were well briefed beforehand about what was expected of them. And this was very important because for a decontamination exercise, the volunteers needed to be comfortable walking around in their swimwear and going through a showering system. So we had to be very detailed in the instructions for the volunteers. We decided to have an age group. We didn't want to have children involved because of the issues around consent. And also we had an upper age limit of 60, which we recognised added some limitations to the event. You can see the breakdown there of the number of casualties and their category on the right-hand side. We had a heavy involvement of amputee volunteers, mainly because of the type of incident we were trying to simulate, which was the Paralympic Games. So we had a large number of amputees. A couple of wheelchair users in there, which gave us some very interesting challenges during the event as well. And you can see able-bodied people, 59 there. And we do recognise that the mental health disabilities were excluded. Again, issues around capacity and consent, which we felt were too challenging for us for this particular exercise. I'll come on to the ID numbers and stuff at the moment. Each casualty was given a clinical script that outlined their simulated injuries and illnesses, and these contained hourly observations, so the emergency services could work with the simulated signs and symptoms which aided in the clinical treatment of these casualties, particularly around the chemical exposure, which was important in determining the appropriate treatment. And they were unique to each casualty. Each casualty had a number, and this was reflected on the script. I think the most important thing for us for this exercise was how we evaluated it. And we had a couple of unique processes here to help us in this. We had the usual things such as feedback questionnaires and debriefing sessions. But for this exercise, what was most important and beneficial to us was the feedback from discussion groups. So we sat all the casualties down at the end, and they had a discussion group, and they discussed openly what they felt and how they felt they were treated and what the problems were, which was important for us in highlighting the issues around the disabilities that affected the emergency services and the challenges that affected them. We had a timing process, which was also important for decontamination. I think those of you that do any running or have run a marathon, you know you get a little timer chip that you can attach to your shoe. We had a similar system during this exercise as well. So we could time how long it took for casualties to move through the process. Because for those of you that are aware, decontamination works on a timing mechanism. And in the UK, that's been done and worked and developed using able-bodied people. So as soon as we start putting people with disabilities through, the timing changes. So that was why this was particularly important for us in this exercise. Sharing performance, that's a technical issue that I won't cover in this presentation, but we were looking at efficiency of decontamination. I think it was really important for us to develop a really good and effective evaluation process at the beginning of the exercise development stage in order that we captured all the outputs of the event. So some of the key outputs, which is what I want to really sort of focus on now. I'm sorry, you probably can't see that with the sun coming in. I think it's in your notes. But the main issue we had, and it's already been raised today, is communication. And this was not only with people with disabilities struggling with communication, it was generally across everybody. In that communication with people wearing protective equipment and chemical suits is seeing and looking through the visors. It's very difficult. And our people with hearing impairments particularly struggle to lip read and to understand through the plastic visors. The clinical decontamination times, I've already said, were outside planning assumptions. So as soon as we put amputees through the decontamination system and they removed their prosthetic arm or their prosthetic leg, that either slowed them down or stopped them completely from going through the system. So this highlighted instantly some issues regarding our planning assumptions for decontamination. And I'll come on to the leg amputees in a minute, but they were basically not decontaminated by the end of the exercise. The emergency services simply didn't understand how to deal with people wearing prosthetic limbs, which for me became as quite a shock. I thought they would understand that, but they didn't. And then there was no, once the casualties had been through the decontamination unit, there was no further clinical assessment, which indicates to us that there's a problem with the clinical treatment and the flow through the system. These are just some pictures here of some of the events that took place, and you can even see here that the two people wearing the decontamination suits are struggling to communicate themselves. So communication is a massive challenge in this environment. Actually, one other photo that's quite good here is on this side here. This chair user was taken out of his chair for decontamination and put on the trolley and the boards to go through. And because he was an upper leg limb amputee, he simply slid off the boards. So there was some challenges for staff about how they deal and work with people with disabilities safely in an environment such as this. The Homerton Hospital was the other place that we used for the exercise, and this was one of the designated hospitals for the Olympics as a main receiving hospital. And as I said before, they were very, very enthusiastic and participated in the exercise fully. In one situation, the volunteers themselves actually ended up being taken into the theatre, into the operating room. The doctors were so keen to participate and to take the patients through, which did worry our volunteers somewhat when they ended up in theatre. We didn't brief them on that. So in the UK, we have a system whereby the hospital will set up a decontamination unit outside the emergency department doors, and this is in preparation to receive potentially contaminated patients. And once the hospital got sort of into action, they actually had quite a good system, and it worked, and they seemed to be particularly well geared up to deal with larger numbers of people with disabilities. They were much better at it than the emergency services at the scene, and I think they were working in an environment which hadn't really changed for the incident, so that's why they were better able to cope. But this is where the decontamination processes here really showed up the challenges that were posed by a large number of people with disabilities. And it came through, in particular, with the showering times and planning assumptions. And again, I mentioned that the communication of instructions. Inside the tents, the people are supposed to follow a set number of procedures in order to wash themselves and to take their clothes off. And in many cases, these weren't visible, or there were no audible instructions for people. So the casualty volunteers simply walked through, or they were showered for longer than they needed to. So the inclusion of people with disabilities in this exercise highlighted that the systems that are in place just simply weren't up to scratch and detailed enough. I have one of the quotes here from one of the casualties, and it says that the casualties expressed difficulties in communicating with the responding staff, particularly at the incident site. None of the deaf casualties reported being able to lip read clinical staff wearing PPE. So it was really obvious right from the start that these people were not going to be able to be treated appropriately or according to clinical procedure, simply because of communication. The hot zone working, that's a terminology, and it's a bit more technical, so I won't go into it in a great amount of depth here. But there were issues around provision of respiratory protection to casualties during or whilst they were waiting in the hot zone, where there's a higher concentration of chemical. And again, this will come down to communication. If you provide someone with respiratory protection, it covers their mouth and their face. And again, it provides challenges for visually and hearing impaired people. Right, the casualty challenges in particular that we noticed were simply that the emergency services didn't understand what to do with people with prosthetic limbs or other mobility aids or hearing aids or with the white cane. They didn't understand what they should be doing with these items. In some cases, the emergency services simply remove them from the people, thereby taking away that person's link with the world. So if you take away someone's hearing aids or their cane, then it becomes much more of a challenge, and we then end up with people who can't be processed through the system as individuals. These 4 people in this picture here have all got lower limb prosthetic limbs, and the emergency services didn't know what to do, so they gave them a chair at the side and simply left them there. And that's not good enough. That's just, they simply didn't understand what they should do, so they're covered in chemical and they just said, sit there and wait and we'll think about it, which really isn't good enough. So as a result, they've had to review and revise their triage systems and consider implications for the inclusion of both disabled and non-mobile casualties. So it did raise a lot of challenges for the emergency services. I think that some of the big learning things from the exercise that we had was that the inclusion of what was a relatively small number of disabled people, actually we can apply the learning to a number of other vulnerable groups. So we should be including the very young and the very elderly in our emergency planning and preparedness activities to ensure that all our plans are fit for the whole community, not just a small part of the community. And I guess as well, certainly from my point of view in terms of developing the exercise, it was a challenge to include a large number of disabled people, but I think from that, it actually made our exercise and made our plans a lot better. And for me, I've learned that we should be including disabled groups much more in our planning generically, rather than just as an addition. They should form a core part of it. And I guess for future trials, we need to look at using volunteers that cover all aspects of the community. For decontamination exercises in particular, it's very easy to use young, fit men who are happy to strip down to their swimwear and go through a shower. But we need to be a bit more challenged and look at different ages, ethnicities and abilities to ensure we get the best out of our exercises and emergency preparedness. So thank you. It's a bit of a rush through, but I hope it's been an indication of some of the lessons that we learned in preparation for the London Olympics. Thank you.